unnecessary risk taking. You may also hear the patient say, I can't take it anymore. Decreased interaction with peers, giving away their personal items, making a will. Suicidal behavior. A suicidal ideation is the thought of committing suicide. A suicidal threat is a direct verbal or written statement of intent. A suicidal gesture is an action that results in minor injury with no intention to die. A suicidal attempt is serious action with intention to die. And of course, a complete or successful suicide is them completing the action and dying. When you are doing a suicide assessment, you need to ask the patient, do you have thoughts or feelings related to harming yourself? Has your mood or energy level changed? Do you have a plan? And if you have a plan, what is your plan? Do you have a means to complete your plan? And is the plan lethal? If the client can completely and without any hesitation describe their plan, and if they have access to the intended method, they are intending to commit suicide. The outcome or the goal for a suicide assessment is for the client to remain safe, for the client to verbalize their suicidal intention to the staff, and to experience less suicidal thinking and identify support systems. The severity index for suicidal risk. It can go from no risk to high risk. No risk is just a fleeting ideation. Very low risk are mild thoughts. They state they will not make an attempt. They can do a contract for safety, and they use their support systems and have a purpose for living. Low risk. They think of suicide as a way to solve problems. They want to escape, but they don't have a plan. Moderate to high risk. They make gestures. They have intrusive thoughts. They talk about it. They give away belongings. They make a will. They do not use their support systems, and they rationalize their religious beliefs. High risk. They want to die. They see no other solution. They develop a plan. It's highly intrusive thoughts, and they may exhibit an increase in energy. If you suspect somebody of being suicidal, you need to observe them and don't leave them alone. Get them help. Remove drugs, legal and illegal, firearms, or any other potentially lethal items from their place that they're staying. You want to assess their belongings and their environment, and you want to try to get them to contract for safety. And you want to make sure that they don't have any medications that they could do an overdose on. Common myths with suicide. People who talk about suicide won't actually do it. People who are serious will show warnings or signs. Young children don't commit suicide. An improved mood means the risk is over. Only people who are depressed commit suicide. A written or verbal safety contract is a guarantee that they will not commit suicide. People who talk about suicide are trying to get attention or manipulate others, and people who attempt suicide are weak or crazy. Those are myths about suicide. Those are not truths. Okay? All right. We're going to go into mood disorders, and we're going to start talking about depression and bipolar. A mood is a prolonged emotional state that affects a person's life and personality. A change of mood is normal, and a range of emotions on a daily basis. They can go from happy to sad and back to happy and everywhere in between in one day. How an individual presents their feelings in association with the mood. Are they smiling when they're happy and grimacing when they're angry? Is their mood observable? Do they use verbal and nonverbal attributes? What are their motor activities like? And what is their mood, thoughts, and feelings through their behavior? This is what an affect is, okay? A mood disorder. When a client experiences extreme changes in mood or emotions and affect, a mood disorder occurs when there's no change in the mood, or when the change is so pronounced that it interferes with daily living, working, attention in school, or involvement in social activities. Moods can be from extreme depression to extreme elation or euphoria. Can be caused by a decrease in your neurotransmitters, norepinephrine, dopamine, serotonin, and GABA. Can be caused by a low point in the client's life, and the client does not have effective coping skills. Sadness becomes depression when it lasts a very long time, such as for 2 years, and it begins to interfere with normal day-to-day functioning. Your differential diagnosis. And what I mean by differential diagnosis is people with mood disorders, you kind of have to see, is it something else that's causing this, or is it a mood disorder? So what are your differential diagnoses? What are your other things that could be causing this? So the symptoms can occur as the result of another mental disorder or a physical disorder. It's very difficult to distinguish a mood disorder from dementia. Symptoms can mimic CHF, nutritional deficiencies, fluid and electrolyte imbalances, infections, or diabetes. In young children, frequent colds may be among the first sign of depression. Patients in isolation for a medical reason are at a high risk of developing depression.
Robin,
Yes.
why with children are frequent colds an indication of depression? Can it just be like, it could be something else though too, right?
It can be. That's why I said it's a differential diagnosis. Right. So if somebody has a frequent cold, you got to look at all the things. You know, it could be depression, or it could be they need tubes in their ears, or it could be that they need their tonsils out. So you have to eliminate the other causes before you can say that it's a mood disorder. But a lot of times, what they say is children that spend a lot of time outdoors by themselves, they don't tend to dress warmly, and
Mhm.
they're not taken care of. They don't have coats and mittens and warm shoes, and
Right.
that's why they get frequent colds, and
Okay.
it's because of their living situation and depression.
Could it also be due to like how stress affects the body negatively,
Could be.
makes your immune system weaker?
Yep. Okay. Depression. Depression is also called an affective disorder. It can be associated with unresolved anger or anger that was turned inward. It is a leading cause of disability in the United States. It is estimated that 9.5% of adults, 8.5% of adolescents, and 2.5% of children in America suffer from depression. Depression can be the primary disorder, or it can be secondary to a physical or other mental disorder. It is common in over 65-year-olds, but it is not a part of the normal aging process. It's difficult to diagnose, and it could be confused with dementia because of the clinical manifestations of memory loss, confusion, agitation, and social isolation. It's twice as common in women as it is in men. Things that may occur along with depression: anxiety, schizophrenia, substance abuse, eating disorders, and personality disorders. Subjective symptoms of depression: a depressed mood, feelings of hopelessness and helplessness, decreased pleasure or interest in activities, and relationships, which is called anhedonia, sleep disturbances, absence in energy, which is called anergia, difficulty concentrating, somatic complaints, and suicidal thoughts. Sorry, I've talked too much, my voice is gone. Children and adolescents with depression are more likely to have anxiety symptoms and physical ailments such as headaches, stomach aches, and other aches and pains. Adults complain of fatigue, headaches, GI pain, and other pain. Those are subjective symptoms. Your objective symptoms, the things you're going to see: a sad or blunted affect, poor grooming, psychomotor retardation, little to no effort to interact socially, slowed speech, decreased verbalization, slowed responses, weight loss, or weight gain. The exact cause of depression is unknown, but it's most likely a combination of factors. So neurochemical or biochemical factors, an alteration in the amount of your specific neurotransmitters, or change in the neurosynaptic receptor sites. And again, your neurotransmitters are dopamine, serotonin, norepinephrine, GABA, and acetylcholine. light and neurotransmitters, so melatonin and serotonin, and change in the circadian rhythm, alterations in your sleep-wake cycle, arousal and activity affect hormonal secretions, and in depression, you'll see a change in your REM sleep and dreaming, insomnia, and frequent wakening. One thing I need to say to you guys, when we're talking about these mental disorders, do not diagnose yourself with these mental disorders that we're talking about. It's very easy to do that. So don't diagnose yourself, don't diagnose each other. You just need to recognize the symptoms of diseases. You need to know yourself in mental health nursing. And if you don't, it will sometimes bring out realizations about you that you hadn't really thought about. I say that because usually every year in psych, somebody says, well, I have this, I have this, oh, I have this, I have this. Everybody thinks they have all the diseases that we cover. So just don't diagnose yourself, okay? Risk factors for depression. It can be hormonal. You can be hypothyroid, endocrine or hormonal. You can have an increased cortisol level and a positive stress response, and that can cause depression. Family genetics. If you have a parent with depression, you have a child has a 10 to 13% chance of getting depression. If both parents have depression, the child has a 75% risk. Twins, identical twins is 45 to 60% that the other twin will get it, and fraternal is 12%. Women have more of a chance of depression than men, and single or widowed have more of a chance than married. Psychological influence, low self-esteem or unresolved grief, lack of social support or stressful life cycles, reactive depression, which is a response to a certain life event, chronic or terminal illness, postpartum, substance abuse, chronic pain, the season of the year, seasonal affective disorder, and experience recurrent depression annually at the same time. The reaction to environmental factors such as climate, latitude, and decreased light can also cause depression. There are many, many types of depression. Transient depression, you really don't need to know a whole lot about it. And mild depression, it's usually triggered by an external event. It's a normal reaction to grief. As you work through the stages of grief, loss is accepted, the symptoms subside, and the activities of daily living are resumed. Some of your symptoms that you will see would be guilt, anxiety, hopelessness, helplessness, sleeping disorders. But once you resolve your grief, those symptoms will go away. You don't need medication for transient or mild. But where you get into problem is in your major depressive disorder. It's a depressed mood or loss of interest, pleasure in usual activities, impaired social or occupational functioning that has existed for at least 2 weeks, no history of manic behavior, and it cannot be attributed to the use of substances or a general medical condition. You have a depressed mood and a loss of interest or pleasure. You also can have a weight loss or gain, sleep pattern disturbances, psychomotor agitation or retardation, fatigue or loss of energy, feelings of worthlessness, impaired concentration, crying, and thoughts of death or suicide. Other symptoms: feelings of despair, flat affect, inability to feel pleasure, lack of personal hygiene, social isolation, delusions, hallucinations, and physical symptoms. That's the umbrella of a major depressive disorder. A dysthymic disorder. It affects 5 to 6% of the population at some point in time in their lives. It affects women 2 to 3 times more than men. You experience feelings of inadequacy, failure, emptiness, a pessimistic attitude, and negativism. It's a learned sense of helplessness. In dysthymic disorder, it's similar but milder than major depression. It's a chronic disorder where you have a depressed mood that fluctuates with a normal mood, and your symptoms are less severe. There's no evidence of psychotic disorders, and you have an essential feature that is chronically depressed for most of the days, more days than not, for at least 2 years. You have a poor appetite or overeating, insomnia or hypersomnia, decreased energy, decreased self-esteem, poor concentration, difficulty making decisions, hopelessness. Early onset versus late onset, before or after the age of 21. Seasonal affective disorder. It's a depressed mood in the fall and the winter. You have a normal mood in the spring and the summer. Possible family history or genetic. A correlation to light production and melatonin production. An abnormal melatonin metabolism. Associated symptoms: hypersomnia, lethargy and fatigue, increased anxiety, irritability, increased appetite and carbohydrate craving, weight gain. Treatment for seasonal affective disorder is light therapy. Early in the day, it regulates your circadian pattern of melatonin. You can also take Zoloft or Prozac.
Question.
Yes.
I'm sorry. So, like seasonal effect, like I was recently diagnosed with that. So like you said, Zoloft, they put me on Wellbutrin for it. Is that something that you would stay on like for the year? Like you're just going to be on it continuously, or do they treat it as the season comes?
I would venture to say you're probably going to be on it.
Okay. I haven't asked her, but I was just, since it's a seasonal, I didn't know if you would just be on it for like half the year, but okay. I would say so too.
It would depends, I would think, on the level of depression.
Okay.
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 Postpartum depression. You have a mild postpartum depression, which is postpartum blues. You have postpartum depression, and then you have postpartum psychosis. So the blues occurs up to 10 days after delivery, can last from a few days to 2 weeks, and the causes are usually hormonal, sleep deprivation, nutritional, stress. There's a labile mood and tearful. 50 to 80% of women get postpartum blues, and it's treated with reassurance and time. Postpartum depression lasts from 2 weeks to 12 months after delivery. 10 to 15% of women get postpartum depression. It's due to hormonal changes, family history, overwhelmed, change in family dynamics, inadequate support. And postpartum psychosis occurs 2 to 3 days after delivery, up to a month. It occurs in every 1 in 1,000 moms. Insomnia, hallucinations, agitation, delusions, voices to hurt the child. The causes are unknown. but they could be biochemical, psychological, or social or cultural. And the treatment is to screen at the postpartum visit, plan for help, and nurture yourself. Teach your clients the signs and symptoms of each: depression, crying, withdrawal, sleep disorders, fatigue, weight and appetite changes, difficulty concentrating, suicidal, fear for the baby. Those are things you need to educate your family on: signs and symptoms of postpartum blues, depression, and psychosis. Your nursing diagnoses: all nutrition and alteration in nutrition, risk for violence, sleep pattern disturbance, and self-care deficit. Just some funny quotes. First one's by Dr. Seuss: "Don't cry because it's over, smile because it happened." And Confucius says, "Our greatest glory is not in never failing, but in rising," or never falling, but rising every time we fall. Interventions for depression. Medications, of course, antidepressants, electroconvulsive therapy, Milieu therapy, and individual and family therapy. About 70% of people are treated adequately with antidepressants. It's usually trial and error to find the right medication, and most treatment is a combination of meds and therapy. Antidepressants. So depression results from a decrease in norepinephrine, serotonin, and dopamine. So the medications block the reuptake of these neurotransmitters in the synaptic space, therefore intensifying the amount of the neurotransmitter. The disorders are a result of decreased levels of the neurotransmitters. So we try to increase the levels of those transmitters. There's 4 classes of drugs. There's your tricyclic antidepressants, your selective serotonin reuptake inhibitors, your MAOIs, and your atypical antidepressants. They will enhance the action of your neurotransmitters. Okay? Tricyclics. The first group, developed back in the 1950s, can be lethal if taken in overdose, and it blocks the reuptake of norepinephrine and serotonin. The chemical structure is similar to your phenothiazines. They don't act as an antipsychotic. They increase activity and alertness, decrease preoccupation with morbidity, improve the appetite, and promote sleep. They're used to treat depression, insomnia, ADHD, panic disorder, OCD, neuropathic pain, and fibromyalgia. Your typical first generation tricyclic antidepressants are your amitriptyline, your imipramine, your doxepin, your nortriptyline, amoxapine, and trypramine, Elavil, tofranil, Pamelor. And this is the thing about tricyclic antidepressants. Side effects of your tricyclic antidepressants: orthostatic hypotension, sedation, anticholinergic, dry mouth, blurred vision, constipation, urinary retention. How many times do I have to say anticholinergic, dry mouth, blurred vision, constipation, urinary retention, dry eyes?
20 more times, please.
20 more? Okay.
Yeah.
Anticholinergic, dry mouth, dry eyes, constipation, urinary retention, blah, 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 blah.
That is not 20. That wasn't
That
even
was.
one.
That was 20. Much as you're going to get. The most common side effect is orthostatic hypotension. You should not take tricyclic antidepressants with MAOIs, antihistamines, alcohol, benzos, and opioids. The MAOIs and the antihistamines are because of the anticholinergic side effects. And the alcohol, the benzos, and the opioids are because they will cause increased CNS depression. Remember, it can take 1 to 3 weeks to see any effect and up to 6 to 8 weeks for maximum effects. Your nursing considerations is a CNS depressant. It can enhance other CNS depressant meds. It can cause dysrhythmias, has a lower seizure threshold, not good for patients with urinary retention, narrow angle glaucoma, or prostatic hypertrophy. They can cause weight gain, and you want to gradually withdraw them or they'll get nausea, vomiting, and anxiety. You want to watch for suicidal risk, suicide potential as the blood levels increase, but not at peak. Watch them if they're suicidal, never prescribe large amounts, and hospitalize until the suicide danger is ruled out if necessary. Selective serotonin reuptake inhibitors. It is the drug of choice. There's less side effects, less anticholinergic side effects, less cardiac side effects, and less sedation. It's less dangerous if taken in overdose. It blocks the reuptake of serotonin. It's the deactivation of serotonin, and it increases the serotonin action as a stimulus to reverse depression. Your selective serotonin reuptake inhibitors, you will hear called SSRIs. They are used to treat depression, OCD, panic disorders, bulimia, PTSD, and premenstrual dysphoric disorder. These are some of your common SSRIs. Celexa, Lexapro, Prozac, Paxil, Zoloft, and Viibryd. Prozac will increase the level of tricyclic antidepressants and lithium and decreases platelet aggregation, thus increasing the risk of bleeding. Side effects: sexual dysfunction, impotence, and decreased libido, as well as anorgasm. Nausea, headache, agitation, insomnia, anxiety, weight gain, and GI bleed. Here's a little cartoon on your SSRIs. And then you have your SNRIs, or your serotonin and norepinephrine reuptake inhibitors. And this is your Cymbalta, your Pristiq, and your Effexor. They block the reuptake of both norepinephrine and serotonin. Side effects: nausea, headache, anxiety, insomnia, sexual dysfunction, weight gain, sweating, drowsiness, and dizziness. It takes 10 to 21 days to see the full effects, up to 5 weeks for maximum effectiveness. You want to teach them about the sexual side effects and weight gain. And they should not be discontinued abruptly, must be tapered to avoid withdrawal. Nursing considerations: history of depression, current medications, liver function, and overdose can lead to seizure. Withdrawal symptoms: headache, nausea, anxiety, dizziness, tremors, and visual disturbances. Okay. Oh. Okay. Crystal, what are the roads like in Frederick?
They're really not that bad. I'm looking outside and the roads are clear, at least in my development.
Okay, what's the temperature down there?
Let me look.
Where do you live, Crystal?
In Frederick, like in Jefferson area.
Okay, I live in Frederick too, so I just didn't know where you were.
Right now it says it's 34 degrees.
Okay.
Oh.
Ashley, what's things like in Ship?
About the same. It's still raining here, sleeting, I guess, but the roads look just really wet.
Okay, you feel safe coming to clinical?
Yeah, I do.
Okay. All right, we will go ahead and have it then. I don't think it's supposed to do anything overnight tonight, but I will keep my eye on the weather for those of you that have clinical in the morning. I think our next realm of bad weather is probably Thursday morning. Okay. Serotonin syndrome. Serotonin syndrome or serotonin overdose. It can be lethal. It occurs when you take another medication such as an MAOI or a tricyclic antidepressant or lithium or Imitrex that affects the metabolism, synthesis, or reuptake of serotonin. It can cause serotonin to accumulate beyond normal levels. The symptoms can occur 2 hours after the first dose, up to 6 days after the first dose. The treatment is to stop or discontinue your SSRI and provide supportive care. It can lead to a hypertensive crisis if used within 14 days of an MAOI. MAOI to Prozac, you need to wait 5 weeks, and Prozac to an MAOI, you need to wait 2 weeks. So if you're on an MAOI and they're going to put you on Prozac, you need to be off the MAOI for 5 weeks before you can go on Prozac. And if you're on Prozac and they're going to put you on an MAOI, you need to be off the Prozac for at least 2 weeks. Any other SSRI, it's 14 days. You do not want to take an SSRI with an MAOI, a tricyclic, St. John's wort, Coumadin, lithium, or an NSAID. St. John's wort, MAOI, and the tricyclics are increased risk of serotonin syndrome, and Coumadin results in increased level of the drug, causing an increased risk of bleeding. MAOIs, monoamine oxidase inhibitors. They are used if other antidepressants fail, and there's many drug-drug and food-drug interactions. It blocks your monoamine oxidase in the brain, thereby increasing the amount of norepinephrine, dopamine, and serotonin available for transmission of impulses. It has a very low safety margin, used if TCAs or SSRIs are not effective, and there's many drug, food, and drug-drug interactions. It's also liver toxic. Your normal MAOIs are Marplan, Nardil, Pam8, and Nsam. Your therapeutic uses are depression, bulimia, OCD, and panic disorder. Your nursing considerations with your MAOIs. Nardil is contraindicated in cardiovascular disease, heart failure, stroke, hepatic or renal dysfunction, and in paranoid schizophrenia. Avoid all medications that are not approved by your doctor. So any over-the-counters, any herbals, anything like that. Inhibit, your MAOIs will inhibit platelet function, so you need to check your CBCs periodically. It can lower the seizure threshold. It takes 4 to 8 weeks for a therapeutic effect. They're very slow acting. You want to refrain from caffeine and alcohol. They should wear a medic alert bracelet. And if they're suddenly withdrawn, they can cause nausea, vertigo, insomnia, headache, malaise, and nightmares. This is your cartoon on MAOIs. You must avoid foods that have tyramine, avocados, figs, preserved meats, most cheeses, and wine. Foods with high tyramine include aged meats and cheeses, smoked or pickled meats, and some beers. A combination of these foods and MAOIs can cause a hypertensive crisis and even death. A hypertensive crisis. It occurs when an MAOI is taken with certain medications or foods that contain tyramine. It's a medical emergency. Tyramine is a form of an amino acid, triosine, and it can cause a hypertensive crisis. It's a result of high levels of norepinephrine not metabolized by MAO. To prevent, you want to avoid the foods and medications that are norepinephrine agonists or stimulator, and you want to avoid while taking medications and for 2 weeks after. Symptoms develop 2 to 3 hours after the ingestion of food or medications. Symptoms of your hypertensive crisis: severe hypertension, occipital headache, stiff neck, palpitations and tachycardia, diaphoresis, flushing, nausea and vomiting, lightheadedness, chest pain, and fever. The treatment for hypertensive crisis is to discontinue the medication, monitor the vital signs, and to give antihypertensives. Okay. I'm going to stop atypical medications. I want to go over a couple things with you guys before I break you for lunch. Okay. For some reason, I don't know why I did, but I had a grading thing in for the behavioral health quiz. That behavioral health quiz is a study guide to help you study for behavioral health. So when you do that and you turn it into me, I will tell you which ones you have wrong. And then as soon as everyone takes it, I will upload the answers to D2L so you can use it as a study guide. The pharmacology quiz, it is a graded quiz. And if you do 51 and 52 and get them right, then that takes off 2 that you had wrong in the main body of the quiz. The grades on that one are pretty good so far. The grades on the behavioral health are not. And we'll go over the behavioral health one after everybody takes it, okay?
And the behavioral health, that's the one where we just pick one section and answer it.
No. That's the behavioral health quiz. It's 58 questions, multiple choice questions.
And that's under assignment?
Yes, it is.
Oh, okay.
And then the mental health homework is the one where you just pick
okay.
one of the 10.
Gotcha. Okay.
And then you have the IV quiz as well and the vocabulary. Even if an assignment is not graded, I will be taking note as to who does it and who doesn't do it. So that will go under participation, so it would behoove you to do them if you haven't done them. Okay? There was something else I was going to tell you guys. Oh, the blueprint for the first exam, I'll put up sometime today. I was going to do it last night, but I fell asleep. This afternoon after class, I have a Board of Nursing meeting, and tomorrow, most of the day, I have a Board of Nursing meeting. So if you need me during the day tomorrow, just text, don't call, because I'll be on the phone, so I'm not allowed to take phone calls. Oh, another thing, while you're at the clinical agency, you are not to leave the clinical agency for any reason. You are to stay at the clinical agency until you are released by your instructor. Those of you that are going to War Memorial, we have been given permission for you to buy your food in the cafeteria, and there is a room that they have reserved for both the Wednesday and Thursday groups to eat their lunch and commune in that room. It's the education room, and your instructor will know where that is. Okay? Those of you that are at Williamsport, just make sure that you take something with you, because I don't think they have a cafeteria or anything there. Okay. What questions, comments, or anything do you guys have for me? I think I told you guys that labs were starting next week. So if you're scheduled for lab on February 3rd or 4th, you are expected to be there, ready to start lab by 9 o'clock. That means have your Go Evo app done and ready to show me at the door. If you don't have the Go Evo app on your phone, you need to do it at the computer and show me the printout. And without that, you are not allowed to enter the lab. You need to have your mask on. If you do not have a mask, you also are not allowed to enter the lab. If you've had any COVID symptoms and you do not get a green check on your Go Evo app, you are not allowed to be on campus. Any questions?
No.
I think you went over it, but what are we wearing scrubs for Brook Lane? Just regular clinical scrub outfits or community?
I wore my
You can-
community top and khaki bottoms.
You can wear your community top and khaki bottoms, you can wear your community top and blue scrub pants, or you can wear your clinical uniform. It doesn't matter.
Okay, thank you.
Those of you who are in lab next week, make sure you wear scrubs. You don't have to wear your clinical scrubs, but make sure you have scrubs on. Okay? And I will see you guys back at 1 o'clock. We will finish lecture at that time. Okay?
Thank you, Robin.
Thank you.
Thank you.